And you're supposed to just do
It's a real thing. What?
It's down.
I think she's like
Anger.
spoke through her. I don't think she
Pulled out anger. Hungry anger.
I think she actually does. I mean, maybe not.
Appetite was there though.
Do you know the test? Like the looking, or which muscle was, which nerve was affected? So it was cranial. What was the name?
I took one earlier.
He was still alive.
Heartless. We have kind of a mad issue.
Because it was saying looking.
Yeah, really. So if you see us like doing weird things, they're just.
That's okay, I'll probably do the same thing to mine.
Both, it's three. Because medial, so the right eye is the cranial nerve.
Flail too. Okay,
Lateral red.
so I think I've got a stable connection now. Let's hope that actually things show up when I write them and we don't have gray screens and all that. If it does, I will consider that this thing is a piece of crap and I'll even do system. So, let's continue talking about the small intestine and we'll do a little bit into the large intestine and then we're going to have a little bit lighter ending to the lecture. There's a video of appendectomy that we're going to look at and I'll kind of narrate it as we go. Okay? So, we'll make a nice lighter lecture for this Wednesday because it's Wednesday and you know, we're all tired. Okay. So we had just finished talking about the duodenum or duodenum, however you like to say it, and how it's a C-shaped structure kind of nestled in the back part of the abdominal cavity, and then we transition from that into the jejunum at the duodenal jejunal flexure. And then we have this long stretch of small intestine, which is divided into the jejunum and the ileum. And so the question here is, how can we differentiate between them, or differentiate if I have it spelled? And really, when you look at the actual intestine itself, there's no real morphological differences. The differences get into the microscopic level, like what cells are there, etc. But we can use the patterning of the mesentery vessels to help us differentiate between them. So typically, typically in the jejunum, this is the jejunum. The vasorecta, so these branching vessels coming out from the mesentery. Mesenteries are very long, okay? While the arches, the arterial arcades, these little arches that the vasorecta come off of are fairly short, okay? In contrast, in the ileum, the vasorecta are short, while the arterial arcades are longer. Okay, so that's just one way we kind of define. Typically in labs, when we look at cadavers, we're going to identify them by what structure they're adjacent to. So we would if we pin the jejunum for a lab twin, it would be near the duodenum, so you would know near that duodenal jejunal flexure, so you would know what area you're coming from. And then also the ileum, we would pin it close to the ileocecal. Yeah, ileocecal juncture. So you would be able to compare the adjacent structures in the gastrointestinal tract. That's, if we pin it in the middle, we wouldn't really be able to tell which way, especially on the cadavers that have all these vessels all ripped out. Can't see them. Okay. Ow. Good grief. to the next junction, the ileocecal junction, and look at a few of the anatomical features of that. So we have the ilium coming in here, and the juncture that is right here. So the ileocecal fold is two flaps of tissue that project out into the lumen of the colon, and they also contain a musculature that forms a sphincter to help regulate passage of the material of the contents of the intestines from the small intestine into the large intestine, and prevent reflux of that. So, sphincter in there, okay? Below the ileocecal opening, we have the cecum, which is that blind pouch at the bottom, the inferior aspect of this junction. And in humans, it's pretty small, but in other animals, I mean, how many guys have dissected like a rabbit? Anybody? Yeah, you know, so the cecum is like this long. So typically in other animals, ruminants and other herbivores, like the horse and the cow and everything, they have a larger cecum to help with digestion of those plant materials. And then hanging off the end here, we have the appendix, which we'll talk about later. Okay? Oh no. Okay, I'm getting a new system. I'm going to go buy my own Chromecast. That's this thing I have in the other classroom, and it works all the time beautifully. So I'm going to go buy one then tomorrow.
And then we can go back to the.
Okay. Welcome back. There we go. Okay. Then let's look at the vascular supply of the jejunum and the ileum. This is nice, easy slide. We just have jejunal and ileal arteries. These are branches off the superior mesenteric artery, and there's a whole mess of them that don't have names other than the jejunal and ileal arteries. You can see here, though, illustrated that kind of this half here has that shorter vasa recta, whereas this half you see the longer vasa recta. Kind of some illustration of what we were talking about before, the differentiation in the patterning of the arterial supply. Okay. Any questions? You good? Okay. So then, this next couple slides is a little bit lighter as well. So just getting a look at some endoscopy images. I'm sure some of you have seen them. So here's just a picture of an endoscope, flexible camera that we can send down the GI tract or up it, whichever end you want to start at, and get images of what the lining looks like. So here we've got esophagus here. And on the left side, we have a nice normal esophagus, so smooth lining, all that. This is esophageal cancer, so definitely not normal. Pretty juicy there. So again, just an example of some endoscope images. And then here we can see, this is the distal end of the stomach. So here, what would this be? Pyloric sphincter, yeah. We'll say S. And then here is the some of the initial parts of the duodenum. Okay, so just some examples for you there. All right, so that's the lecture. Then we'll switch over and do a few more slides on abdominal 4 PowerPoint. And so just go through the general morphology and location of the colon, and talk a little bit more about the appendix, etc. So here I just want to point out the path the colon takes. So it starts off here in the lower right-hand portion of the abdomen. We got the cecum there, and the appendix, and then the ascending segment here runs up the right flank, and then the bend part here hiding under there, it would be the right colic flexor. We'll look at an image with that better later. Then we have the transverse colon kind of running along the lower part of the epigastric region, and the left colic flexor bending it down to come down through the descending colon. And then finally the sigmoid colon, this S-shaped structure that goes from the descending colon down to the rectum and the anal canal. Again, making sure that you know what region contains which organs. This will be building on that and just re-emphasizing that. So then let's look a little bit closer at, there we go, some of the morphological features. So I already talked about the ascending colon, the right colic flexor. The right colic flexor, I do want to point out, is also called the hepatic flexor. Because it's near the liver. So that's nice and easy to remember. The transverse colon here, and then the left colic flexor, this is often called the splenic flexor. Then finally the descending colon and the sigmoid colon coming down. A couple of features I want to point out are the oh gosh, I'm gonna have trouble saying this one today. Anybody know how to say Tinea coli? Yeah, anyways. So this is a batch of longitudinal muscles. There's 3 of them. And so they kind of are, so here, if there's the 3 there, they kind of are spread out with the rest of the wall of the intestine kind of looking like the 3 leaves of a clover, kind of like that. So those are longitudinal muscles there. We also have rings of smooth muscles going around the circumference here. And there's smaller rings here, which create the haustra of the colon, so those constrictions of the colon there. Okay. Here's just a look at the colon with the following the barium enema, and you can see the different structures. How the ascending colon here. Which flexor is that? Hepatic flexor. Yeah. The transverse colon running across here. This one is the which flexor? Splenic. Good. And then something just to note here. Remember when I was talking about the mesenteries? Was it yesterday? Sometime this week. I said that the sigmoid mesocolon is a little bit longer and allows some variation in the positioning of the sigmoid colon. Well, this is a good example of it. So it's wandering around all over here rather than being that nice simple S shape that we see in the diagram. So just an example of that inter-individual variation in the placement.
So is that normal?
Yeah, perfectly normal. You'll see all kinds of different variations in between patients. Okay. So we looked at some of the internal structures of the ileocecal junction. I want to go back and look at some of the external structures. So again, it's located here in the lower right quadrant. And I just want to point out, right, the mesoappendix, which is a mesentery-like structure that helps hold everything in place, especially the appendix holding it to the ileum. And then we have the cecum down below here and the appendix coming off in line with the tinea. So if you trace the tinea down to the end of the cecum, it will lead you straight to the appendix. And then here's again another image, you can see, the ilium coming up through here, kind of tucking in for the ileocecal junction there, and then the cecum down below here before you head up the ascending colon now. Any questions so far? So often, the diagnostic images of the bowel are very variable. So like with the sigmoid colon, small intestines, they just look like a mess to me. But as you would get used to reading them, obviously more would come out of it. But there is again a lot of variation exactly where each of the loops in the bowel is placed. Excuse me. Okay. So then, what arterial supply does this area of the large intestine receive? So ultimately, it comes from the superior mesenteric artery. Okay, and then I just want to point out the ileocholic artery. That's kind of the major branch off of which stem the anterior and posterior cecal arteries. So they're going to send blood supply to the cecum, as their name it suggests. And then the appendicular artery, which obviously sends the blood supply to the appendix. So this is one of the simpler things, simpler arterial supplies that we have to learn for this section. Thank goodness for that. So then let's talk about the appendix a little bit more. So the appendix is this blind tube here. It contains a lot of lymphoid tissue. In its walls. And it is a tube, so it's got the opening here onto the cecum. And then when it gets blocked, obviously, things start festering and there becomes inflamed. That's when you have appendicitis, and we'll be watching the video of that being removed. Also to want to note that there are several different positions the appendix can take. So the normal one that we see in the diagrams is we refer to the pelvic position of the appendix, but it can also be kind of rotated inferiorly to be subcecal. It can be turned underneath the cecum as the retrocecal, or it can be flipped the other way and be either behind the ileum, the post-ileal, or in front of the ileum, the pre-ileal position. So just several different positions to be aware of that the appendix can be. Okay. All right, so that is the part of the lecture I wanted to go over. Now let's see if I can get this video thing going. PDF files. So this video is from a laparoscopic surgery. So I've inserted the camera into the abdominal cavity. They didn't blow up the abdominal cavity with CO2, so they got room to work and ability to see. And then you'll see all of the laparoscopic surgical tools coming in on their little probes. I am actually constantly amazed at the coordination of those surgeons to be able to play with things outside the body and have it work inside and make it, that's amazing.
I walked into my apartment, there was a wasp just hanging out on my backpack. Spencer was like, put your backpack down. And I was like, what? Just throw it. Put my backpack down. Set it on the ground. I was like,
Okay.
look.
So there we go. So we have the, like, oh, yeah, I can do that. Or, oh, on the wall, like a normal room, oh my gosh. Okay, here we go. So here we got the camera inside, you can see, that fatty stuff, what would your guess be for that?
Greater Aumenta.
Yeah, probably the greater momentum, kind of laying on top of things, very good. And also some mesenteries flopping around in there. Kind of getting their orientation there. Looking around. Whoa. Kind of crazy. You're having some fun there. Okay, and this is before they had inserted the surgical instruments, so now you can see them trying to insert the surgical instruments. And it takes a while for them to get into it. So you can see them pushing through, and some more bleeding as they're rupturing blood vessels in the abdominal wall. There's lots of bedtime in this video. It's just like, what's happening? They must have been having a conversation or something.
Oh, they made me.
So they're working outside there right now?
Yeah, so they're outside. The only thing is in is they got a tube with kind of like a port inserted in the abdominal wall, and then their camera goes into that. That's what's inserted right now. Now what they're doing is inserting the surgical tools. So they must have gone to get coffee or something. Okay, so now we're making progress again. So pushing down through the abdominal wall and start to see it come through.
This is what they did to you.
I know.
This is traumatic. You're like, hurt so
Gotta clean the lens off. Now we go back in. So you can see that port now, that little white port that's inserted in the abdominal wall.
Oh my god. Yes, it's you.
Oh, got some gauze flying off the lens. Back in. Oh, there we go. First surgical instrument in. Oh, you go in.
Can't see it.
sometimes it's not that they're just cleaning the lens off, they're jumping boards so that they can get different angles. And so sometimes it's, they're switching between their different equipment, and instead of having it just hanging in the board, that's why they'll pull it out and have it sit there.
Ah. Very interesting. Insider content available. Where's that? Okay. We're moving some of that, momentum out of the way. See that suction? Yeah, get some suction.
Smells very satisfying.
Yeah, there he does it. His is actually kind of gross now. You didn't look at that time.
Oh, got some bleeding going on here. Okay, so. That's rather large and not looking good. I'm really amazed that they can wrap anything with those tiny little things on long
Those are Carl's.
So that, there's that,
Oh, no. I wonder what's gonna happen.
There's that, mesentery, that little folded mesentery we were talking about just earlier, holding the appendix in place. Okay, so that,
Or like that.
Bowel out of the way.
Like the
On
one
the
underneath.
mesentery. Still one.
Get on.
Yeah. Like fat.
Okay, now this is a cool part. This is pretty awesome. This is we cauterize the tissue. That's pretty gross.
And then it smells like chicken.
Yeah, then she's like, once you swallow calories, it just.
You come in and trim the cauterized tissue, so you got access to the next section.
the whole thing.
Like here?
No,
Here?
yeah, underneath there.
I think that's just part of the cecum there. So that's part of, some part of the larger intestines there. That's not as much as I can cut it. So the whole thing is just enlarged from what it would normally be.
Leader.
I can see it, pulsing, is that not agree?
Quick, quick.
Quite good. I check and make sure they got the whole leader.
Cause that's where the artery for the appendix goes, right? That's where.
Yeah, that's, up in.
The main-
medullary artery goes right through that mesentery. Remember what that mesentery is called?
The mesentery.
Uh-huh. Just talked about it. Okay, so now they're bringing in some suture material, and, they're going to tie off the appendix. And any guesses why they would be wanting to do that?
They're gonna cut it out, leak it.
Yeah, so we don't have any leakage from bowel contents? Or, yeah, just from the appendix too. And this, honestly, I think it's amazing, you can tie a knot with those things. I mean, holy cow.
There's a lot to that.
Look. What are they doing? Pulling all the way out and doing all the way out.
If you watch that above the knot that they're tying, you can see how the tissue above it starts